Thank you, madam, for such a lucid talk. And we have got a few questions in the chat box. With your permission, I'd like to begin with it. So first question comes from Divya. It's how to manage menorrhagia in PCOS and how common it is to have menorrhagia in PCOS.
Young people with polycystic ovary syndrome more frequently have oligomenorrhea rather than menorrhagia, but menorrhagia can occur because they have an abnormal LH to FSH ratio with a grossly elevated LH, usually about 3 to 4 times at least higher than the FSH. And so you get quite erratic amounts of estrogen, a very abnormal endometrium. And that's why when you have an endometrial thickness of 10 to 12 millimeters instead of 4 to 6, that's why you tend to get bleeding. So the easiest way to manage it is using a contraceptive pill with normal cycles. I would always choose an OCP that does not contain norgestrel because norgestrel is relatively androgenic. I use a low dose pill with 30 to 35 micrograms of ethinyl estradiol plus norethisterone acetate. And that will usually do the trick.
Thank you, ma'am, for the answer. And the other question is, spironolactone, when started for hirsutism in PCO, cause spotting and sometimes a bit heavy too. So what other options should be there? We opt for the management of PCO.
I dislike using spironolactone by itself. There's a number of issues with spironolactone. Please, if you're going to use it for PCOS, you need an absolute minimum of 100 milligram per day. I find that 150 milligram per day is better. If you use anything less than that, it's a mild diuretic, but it is not anti-androgen. So its anti-androgen effect is only at much higher doses, and so there's no point in using it in low doses. It causes either polymenorrhea with periods every 10 days or severe oligomenorrhea or even amenorrhea. So I almost always use it in combination with a low-dose oral contraceptive pill, and together the two have a synergistic effect, and it's usually very effective that way.
Thank you so much, ma'am. Madam, you gave some options for developmentally delayed or challenged girls about intrauterine device and other things. What is the role of desogestrel in such kids if we start?
Desogestrel is a third-generation progestogen. There is something to be said for using a first-generation progestogen if you're going to choose one at all, because they are less procoagulopathic than the third-generation ones. So if I was going to make a choice of using a progestogen, I would tend to use norethisterone acetate or medroxyprogesterone acetate rather than desogestrel. That's my first point. The second one is that, yes, you can use them, but by themselves, they tend not to stabilize the endometrium or reduce it to the point where you get no periods. And it's interesting that some years ago, I conducted a program at a specialist school for severely disabled young people and asked parents what they thought of various options that they had been given. Universally, they had all been given either oral progestogen or the oral contraceptive pill. Universally, these failed. The girls had irregular bleeding, they were grumpy, they were horrible, nobody could understand what was wrong because many of them were non-verbal. And the vast majority wished to change to a progestogen-bearing IUD, which was like a gift from above. So you can get these things. They're very expensive to start off with, but they last for 5 years. So the expense is dissipated. And in many hospitals, the hospital will help pay for them.
Thank you so much.
For this, we will have to take ethical clearance also, right? This IUDs and other things.
Yeah. So the other question comes from Anshika. Is there a lower age limit for giving norethistron for menorrhagia?
No, not really, because if somebody has been through puberty and finished their development, they have an appropriate level of estrogen for a young woman, even if they happen to be 10 or 11 years of age. There's nothing wrong with giving them progestogen, nothing at all.
Okay, thank you, ma'am. And one more question: how to approach menstrual cycle in an adolescent that consists of spotting for 15 to 20 days without over bleeding for more than 2 cycles? I mean, that the patient has started spotting and this continues for 15 to 20 days without a proper menses. So how do we approach to such kind of a menstrual cycle?
Well, the vast majority will be easily treated with progestogen. So the appropriate thing to do will be to give them, my usual thing is to give them just 10 milligram per day of Provera for 2 weeks, and then stop the Provera, the endometrium will be shed, and then they'll go back to normal. But you can use that if you get recurrent polymenorrhea. You can use it, as I said, from day 10 to day 26 of a menstrual cycle, and that will provide the progesterone that the normal cycle is not providing, and will allow the endometrium to remain stable for longer.
Thank you so much, ma'am. On the last question, we would like to know the role of metformin in lean PCO with menstrual irregularities.
Metformin, generally speaking, I mean, it's used to help weight loss by increasing the peripheral utilization of glucose and decreasing hepatic storage of glucose as fat. It has a side effect, obviously, as you know, of making the girl feel slightly unwell, and often she reduces her intake for a while. Unfortunately, that effect doesn't last for very long. But even a 5 kilogram weight loss initially will usually bring the cycles back to normal. And secondly, if you look at women who are wanting to achieve a pregnancy and who have PCOS, treatment with metformin alone will usually increase ovulation by a factor of 10. It's not always perfect, but it's very useful. So its exact mechanism is probably via weight loss.
Thank you, Dr. Margaret. There are a few more questions, and I'm sure more questions will be popping up. So we would appreciate if you could answer in the chat box and also in the question and answer box. Thank you very much. I think we will move on to the next topic. Stuti, we welcome Professor Paul Hoffman and also Professor Olaf Ward for this session. Dr. Paul Hoffman is Professor of Pediatric Endocrinology, Director of Liggins CRU. He's been past president of HYPEG and ACES. He has had a lot of publications, more than 240 papers. He has done more than 150 oral presentations and symposia and plenary talks. And again, he's not new to our group. He has come to India, and I'm sure he has also come to Bangalore for our last 2013 ISPAE conference, and enjoyed whole of the conference for 7 days. And the topic what he would be discussing is delayed puberty. And many times all our delayed puberty children go to either gynecologist or family physicians. They only land to us very late. I think we have expert for the talk. We welcome Dr. Paul Hoffman.
Thank you very much, Ayla. I have to say, it seems like forever since I was last in India, and I sincerely hope I'll be able to get back there soon. It's just the most amazing country. I always consider it every state a country in its own right, so it's like countries within countries, but it's an amazing place, and I am certainly looking forward to getting back there in the next year or so. So again, thank you for inviting me to take part in this series of talks. The topic I was given today was on delayed puberty in girls, and I have entitled that Failure to Launch. Can you hear me? Okay, cool. Okay. There are a number of useful reviews in this area. I'm very happy for this talk to be recorded, or I'm happy to send a copy of it so that you can look at it in the future. But these are a number of reviews that I think are very helpful if you want to have something to look at later. Now, the physiology of normal puberty, we don't really understand that much of it yet. We have a better understanding than we did, particularly around some of the genes that are involved. We know that your general health and nutrition are important. We know that endocrine disruptors are important, and environmental cues, including societal changes, all play a role. One of the ones that I see here in our Indian community in New Zealand are we have a number of children who have been adopted from India, and they have a very high incidence of precocious puberty, and that's a well-known phenomena internationally. And we are aware that in Europe, but other countries too, and other continents too, the age of menarche has dropped. And in Europe, it's dropped by around 5 years, from 17.5 to 12.5 years. It hasn't changed that much over the last few decades, so we might be getting close to the lower end of that range. That said, interestingly, breast development is occurring somewhat earlier, and so there does seem to be a bit more of a disconnect between earlier breast development, which does not necessarily mean puberty, of course. It means exposure to estrogen, and menarche occurring. Now, you will all be aware, I'm sure, that the hypothalamic pituitary gonadal axis is active before you're born. Towards the end of pregnancy, you get a repression of puberty, and then that activates 1 to 2 weeks after birth, and you get a mini puberty during infancy of over several months, somewhat longer in girls and boys. That puberty is really around reactivation of the hypothalamic pituitary gonadal axis, and includes gonadotropic releasing hormone pulse generator, which I'll talk about in a second, and the gonadotropic cells, the pituitary and gonads. Now, there are neurons called Kindi neurons, which co-express a number of proteins and at nerve endings, including kisspeptin, neurokinin B, also called TAC3, and dynorphin, and these act as a pulse generator in the arcuate nucleus of the hypothalamus. We know that this pulse generator remains quiescent due to central inhibitory signals, so it's turned off, and as these reduce, the subsequent increase in GnRH secretion and reawakening of the axis. Now, it's somewhat more complicated than that, but I'm going to take you to a very simplified version. There is a number of factors we know are involved now. One is called macron ring finger protein 3, or MKRN3, which is a polyubiquinator. So it sticks on ubiquitin groups, and in particular onto this protein called NPTX1, which we think is very important in initiating puberty, although we're not sure how yet. But if you ubiquinate it, you degrade it, so you can't start puberty. So pre-pubertally, this macron ring finger protein 3 is high. And in fact, if you have a mutation in it, so it goes low, and you can't ubiquinate this protein and get rid of it, you have activation of puberty early, and it's one of the causes of precocious puberty. And before you're going to puberty, you have an activation of your, or lack of activation of your kisspeptin receptor and in the GnRH neuron, and you don't get your GnRH pulsatility that you need to activate gonadotropes. At puberty, it all gets a bit more complicated and there's lots of question marks. You have in the hypothalamus, or further up in the hypothalamus, the neurokinin B or TAC3 receptor, activating kisspeptin and kisspeptin receptors, which activate through those Kindi neurons, your GnRH pulsatility. You have this increase in NPTX, which also increases excitability through reduction in the MKR and through a macro ring finger protein 3. On top of that, we have effects of both insulin and leptin on this hypothalamic axis, potentially on these neurons. And we know that if you are undernourished and have a very low leptin level, such as an anorexia nervosa, or you're markedly insulin sensitive, then this doesn't turn on normally. So you need insulin and leptin around, at least at a permissive level, for activation of this axis 2 to start this GnRH pulse generation. And this is a very old graph, but I think a very important one. Just as we talked about, you've got two factors here. You've got the gonadostat and dashed lines up here, and as that turns on, these are your central neurons inhibiting puberty, and the actual puberty itself is in this dark line, and you can see it was fully pubertal before birth. At birth, you're inhibited, and then you, after 1 to 2 weeks afterwards, you go into a mini puberty, which lasts through infancy, and then you turn off puberty into late childhood, and then puberty reinitiates. And generally, at an age of around 10, a bone age of 10, which tells you about essentially about physiological age, will give you an idea of when puberty really starts again. We'll come back to that bone age of 10 because it's very useful when looking at assessment. Now, in terms of delayed puberty, and that's depending on your definition between -2 to -2.5 standard deviations above the mean in terms of age, that reflects, you would think, around 2% of adolescents, but in actual fact, it's more than double that because of a range of other issues that occur, particularly the functional hypogonadotropic hypogonadism. By definition, normal puberty is between 8 and 13 years in girls and between 9 and 14 years in boys. So in girls, absent breast development after 13 years is considered delayed. Now, we generally and broadly split this up into 4 groups. We have probably the most commonest group, which is the constitutional delay of growth and development. This would be around 80% in boys, but it may be as low as 50% of girls. Still the commonest group, though. We have primary hypogonadism, where you have elevated FSH and LH because of a lack of negative feedback. This is classically Turner syndrome, and around 20% or so of girls have this as an underlying cause for their delayed puberty. Then we have central hypogonadism, so an inactivation centrally. And finally, we have functional hypogonadotropic hypogonadism. And this is where the central axis is turned off because of stress, lack of weight, underlying chronic illness, etc. So there's a range of reasons why that occurs. And that occurs relatively commonly in girls, possibly up to 30% or so. And so because of these other aspects, when you look at delayed puberty in girls, the range of diagnoses is somewhat different. Constitutional delay, as I said, is very common in boys, but in girls with delayed puberty, it may reflect generally around 50% of girls. And in this condition, and this is probably the most important condition because it's still the most common in girls, the girl's height is well below that expected from their genetic potential or their mid-parental height. So let's look at a case. This is just an example. So in constitutional delay growth and puberty, we expect their growth velocity to be normal, as it looks like early on. We expect the birth weight to be normal. Usually, but not always, there's a family history of pubertal delay and of late growth. Now, in terms of pubertal delay, women have got much better memories than men, as all the women out there will tell you. And so they'll be able to tell you that they had, when they had menarche, and if it's after 14, it would be considered late. Men generally have amnesia, in my experience, between the ages of 10 and 40. And if they remember anything, they remember being a bit shorter than their friends and growing later. But honestly, men are pretty useless historians about puberty. In terms of examination, the con delay group, they have a bone age delay, usually not more than 2 years, but it can be more. And their final height is normal because they grow later. So if we have a look at this graph here, this child is growing poorly, but if you look at the mid-parental height, it's just above the 50th percentile with a range that plus or minus 8 to 10 centimeters. Still, this child's well below that for projected height. The growth has also fallen off considerably by the age of 14. In this family, the mother didn't get breast development until she was 14, 15, and didn't have periods until she was 18, so very late, even for a girl. But if you looked at this child's growth subsequently, you see she grew very fast once she hit puberty, which is around 14 years of age. And if we look at her bone age, we can see that it was consistently 2 to 3 years delayed, but more than normal possibly, but very consistent for a mid-parental height. And that's a sort of background that you get, possibly a bit more extreme than most. But the important point I want to make is that when you have delayed puberty, you often have short stature. And it is often the short stature, not the pubertal issues that bring the child to you. So differentiating what's going on is important. The other issue is growth velocity being normal. And you can see here, when they hit puberty, the growth velocity is not normal, at least not for other girls. The question is, what is normal for a teenage girl who is not in puberty? So if we look at this growth velocity chart here from the CDC, we can see normal growth velocity on the 50th percentile, the dark column there, and the pubertal surge, and with a peak around 11.5 years. The blue line here represents delayed puberty with, in this case, puberty, a growth spurt around 13 to 14 years. But what if you don't have that growth spurt? The best way of looking at it, I just draw a line down to give myself a 50th percentile. It's approximate, but I find a very effective way of looking at it. So by 14 years of age, if you're not in puberty, a child should be growing around 4 centimeters per year. If they get to 17, a growth velocity around 3 centimeters per year is normal. So when you're thinking about growth velocity, which I think is very important when you're looking at chronic illnesses like celiac disease, you need to know what the normal growth velocity for the age of the patient is. And this gives you an approximate way of assessing that. So when we're looking at constitutional delay, they have a characteristic history. Generally, they grow normally over the first few months of life, and then they have a period of what appears to be failure to thrive. They cross percentiles downwards for up to 12 months or so, and then when they hit a particular percentile, they then grow parallel to that percentile until late childhood. And of course, if you've got a family who is short and a child does this, they appear very short during childhood. They then go into puberty late, and it's in those last few years when all their friends go into puberty that they look even shorter, but then they keep growing and their final height is consistent with their parents' height. One of the important points about constitutional delay of growth and puberty is that it's a diagnosis of exclusion. So it's something that we look at once we've excluded other causes. Let's move on to functional hypogonadotropic hypogonadism, probably the second most common group that we see. 20 to 40% of girls will have this as the cause of their delayed puberty. The most common I've put down the bottom actually is negative energy balance with weight loss, which is up to a third of girls have this due to anorexia, due to excessive exercise, and occasionally, depending where you are in the world, due to malnutrition. There are also, of course, a range of other diseases that can cause this, including chronic inflammatory bowel disease, celiac disease, a range of illnesses that I've put there, as well as a range of endocrine issues, which are even rarer again. So when you think about delayed puberty, always make sure that you're thinking about the functional causes as well, particularly those associated with weight loss and exercise. The primary hypergonadotropic hypogonadism is very uncommon in boys, but very common in girls because of Turner syndrome. Up to 30% of girls may have this as opposed to 5% of boys. And it becomes apparent when the bone age is above 10 years. At that stage, your LH and FSH, the hypothalamic pituitary gonadal axis will be turned on, and your LH and FSH will start to rise. By far and away, the most common cause is Turner syndrome, but there can be rarer causes, premature ovarian failure due to autoimmune conditions or due to genetic conditions such as serogenic factor 1 haploinsufficiency. You can have a background of chemotherapy or radiation, or you can have other causes of gonadal dysgenesis other than Turner syndrome. So as I say, there are a number of causes, and these become apparent after 10 years with a bone age of greater than 10 years. If you're fortunate enough to have done tests when the child was in mini puberty, you can sometimes make a diagnosis at that stage in Turner syndrome. but usually this is something that occurs later. And finally, of those four, you've got the permanent hypogonadotropic hypogonadism. This is your central hypogonadism. Causes include congenital hypothalamic hypogonadism, which is over 50% of the cases. These can be anosmic, and we refer to these generally as Kallmann syndrome, and normosmic. The anosmic can be hyperosmic, so it's not always completely a lack of smell. A number of other genetic causes include combined pituitary hormone deficiencies such as PIT1 or septo-optic dysplasia. There can be CNS tumors and infiltrative diseases, as well as the result of chemotherapy, with chemotherapy or radiation affecting the pituitary or hypothalamus. So not all of these are congenital, some of these are acquired. Important to remember that this is a highly variable spectrum. We always think, well, I always think of a central problem or any gonadotropin deficiency as absolute, but that is not the case when you're looking at these congenital forms, and there is frequently partial puberty variants, the so-called fertile eunuchs, and the reversal in their late teens or in the 20s of congenital hypothalamic hypogonadism, and they go into puberty. Causes for that remain a little unclear, but there are clearly genetic causes which can be to some degree reversible. Of the girls, 10% of the girls who have diagnosed congenital hypogonadotropic hypogonadism have menarche, and 50% get some breast development. So remember that just because you do develop breast development does not mean that you don't have CHH. In terms of genetics, and this is normal versus delayed puberty, we know with normal puberty, it's a highly polygenetic trait, and in twin studies, up to 80% of pubertal timing is due to these additive genetic factors. Now, we don't have as much in males because they don't have periods, and that's a nice, easy thing to remember with the genome-wide association studies. However, we get similar results between sexes in terms of the genetic contribution. There are a number of genes involved, and these include imprinted genes and MKRN3, which I talked about earlier, and DLK, but loss of function of both of those paternally imprinted genes can result in precocious puberty. And there are microRNases, such as in the LIN28 gene, which regulates a range of microRNases, and they may modify epigenetic effects such as neglect, nutrition, endocrine disruptors, and modify puberty as a consequence. When we're thinking about the constitutional delay of growth in puberty, 80% of this is heritable. We know this from discussions with first-degree relatives. A number of genes have now been described, and as you can see them there, there's the fat mass and obesity associated gene, there's the heparin sulfate 6-sulfide transferase gene, enhanced at puberty gene, and the immunoglobulin superfamily member 10, among others. But these are the most common ones. What is interesting is that they almost completely overlap with other causes of congenital hypothalamic hypogonadism, suggesting this may be a spectrum rather than two discrete conditions. So 50% of your CHH patients carried a mutation in at least one known CHH allele, and this is in one study versus 7% for the CDGP group. So you can see that there is an association going on there. If we look more closely at these two groups, if you look at the anosmic group, this is the Kallmann syndrome group. CAL1, which is anosmic, the X-linked group, is what we consider traditionally as Kallmann syndrome. But we know there are now 6 versions of Kallmann syndrome caused either by the FGFR1 or its ligand FGF8, the PROC-R3 or its ligand PROC2, or CHD7, which is, of course, charge association. So we've got now 6 versions of Kallmann's which can cause either anosmia or hypoosmia. And they do this either by affecting migration of the olfactory bulb and the GnRH neurons, and these include your PROC1 and PROC-R2 receptor, so PROC2 and PROC-R2 receptor, your COL1 and your CHD7, your charge association. All these associated with anosmia due to this, or it can be due to GnRH neurogenesis and that affects your olfactory epithelium, and that includes FGF8 and FGFR1, your heparin sulfate 6-ST, and NALF, which I won't go into at the moment, but that also affects your GnRH neurons. With the normosmic congenital hypothyroidism, we are looking at a number of more obvious things: your beta FSH and FSH receptor, your GnRH and GnRH receptor, kisspeptin and kisspeptin receptor. Then you have your TAC3 or neurokinin B, and TAC3R, or your tachykinin receptor 3, and the NALF. All of these have been associated with normosmic central hypothalamic hypogonadism. But it is a lot more complicated than that, and this is not a genetics talk, and I do not want to spend hours on genetics. But I think this slide from the Asian Journal of Andrology, I think it's a very nice one, linking precocious puberty, a healthy population, normal delayed puberty, and central hypothalamic hypogonadism. And there's overlaps for many of these things into both. And I think that's what we're going to find more and more, is that we've got DLK, MKRN3, KIS1 and KIS1R causing precocious puberty, but also being associated with GnRH deficiency. You've got combinations of GnRH deficiency evolving into delayed puberty that can cause both. And there are some which have just been associated within a healthy population, a normal range. So I think that these are the sort of these are the sort of genes that we'll be looking at when we look at pubertal changes or differences. So just to summarize, so in adolescence, which is what we're looking at here, because this is delayed puberty, the 4 things to think about: constitutional delay of growth and puberty, functional hypothalamic hypogonadism, which between the two of them would be about 70% or so, primary gonadal failure, primarily Turner syndrome, and permanent hypothalamic hypogonadism, which is about 10% or so of the cases. Now, as I said earlier, almost all these patients present with short stature, and that may be seen as the primary problem. So it can be quite tricky sometimes determining whether the primary problem is a growth disorder or a gonadal one. And that is where measuring growth velocity is absolutely essential, and understanding how growth velocity changes as a child ages, particularly during adolescence when they go outside the normal growth velocity chart. Now, in terms of first line evaluation, you need to get a family history of pubertal onset in the parents, obviously menarche in the mother, how long the father grew for, if you can get that, parents' heights to work out a mid-parental height, any background history of chronic illness, medications such as steroids that can affect growth. Consanguinity is really useful, as well as, of course, a history of exercise, anorexia, psychiatric conditions, and medications, all of which can cause more functional issues. Current growth, including BMI, is essential. Height velocity can take another 6 months to get, because you need to have 4 to 6 months of good height data to establish that, but really very important in terms of working out what's going on. And of course, examining the child for dysmorphism, for the sense of smell, for chronic illness. And when you've gone through them, generally you don't find an awful lot, but the one test you always need to do, of course, is the bone age. Remembering that your hypothalamic gonadal axis is generally not activated if your bone age is less than 10 years. I generally also get a basal LH, FSH, and estradiol level. The LH level on most sensitive newer assays of greater than 0.3 will indicate central activation of puberty, so it can be really helpful. It's more useful in precocious puberty, but does have a use in delayed puberty. Depending on what you find, I would do an occult illness screen, although generally I would leave that till I have some growth velocity data. And that would include electrolytes, your full blood count, CRP or ESR, celiac screen, thyroid function test, karyotype, usually very early on with if I've got any concern around short stature, and of course prolactin, and sometimes other hormonal assessments, including growth hormone provocation testing. And here is one approach that has been suggested, and that is looking at basal LH and FSH levels. They're talking about after 13 or 14. I would be saying if the bone age is greater than 10, irrespective of your age, and usually it'll be 12 to 13 years, that's the time to do it. If you have a low or normal LH and FSH level, they say for early Tanner stages, I don't think you need Tanner staging because most of that is adrenarche. Then you look at the growth velocity. If it's appropriate for age, then you think about GnRH deficiency or constitutional delay. And you can go down that loose. I would never do a GnRH stimulation test. I think they're too insensitive. But you may want to look at other things, particularly if you're concerned about Corman's or genetic testing. The one test I might do is a brucerin stimulation test, and I'll talk about that in a second. If the growth velocity is reduced, however, that's what you see with undernutrition, with anorexia, with over-exercising, with chronic illness. And so you can split it up in terms of whether they're low weight, normal weight, or high BMI, and look at the underlying causes, of which these not all have been listed there. And finally, of course, if your FSH is elevated, that's really going to push you down the primary hypogonadal route, karyotype, and potentially looking at ovarian autoantibodies, and AMH level, and again, genetic testing if required. So again, just a paradigm to work with. Now, in terms of second line test, as I said, if you've got a child who is growing well, you think may have constitutional delay of growth and development, you can go forward to do a bucerin stimulation test, which is a GnRH agonist, a super agonist you can use. There's a range of them out there. That's the one we have most experience with in Auckland, and we published on this in 2006. And we had very good, if you had a bone age greater than 10, we had very good separation of those who were normal and those who had abnormalities. And we've used that for years. And whilst it's not 100%, it's actually a very good test to try and define what is abnormal and what isn't. More recently, there have been a couple of tests out there which I have no experience with, but look very interesting. One is using kisspeptin to stimulate LH, and a level of less than 0.4 was 100% of the time associated with a central defect. And the other is using FSH stimulated beta inhibin, and levels less than 116 picomoles per liter were associated with almost universal central defects. So these are tests that might be coming, but I certainly don't have access to them currently. And the other thing to remember is looking at gene panels, either targeted ones or looking at whole exome or whole genome sequencing. These are becoming increasingly useful because so many of the defects that we see are associated with genetic abnormalities. Now, when it comes to management and investigation sort of blend a little bit, there are two approaches. One is to wait and watch, and one is to initiate puberty. Waiting and watching is a reasonable option if the teenager is not too concerned about their height and not too concerned about being prepubertal. And there are quite a few children like that. And often we get boys or girls sent to us because parents are worried rather than the child. So you need to consider the psychological issues of being prepubertal and being short. One of the things to remember, if there are concerns, even if therapy doesn't increase final height, getting there more quickly can be beneficial. So if there are issues, I have a low threshold for using treatment. If you have an age of greater than 13 in a girl and greater than 14 in a boy. In terms of pubertal induction, I tend to do this as my therapeutic trial. You could do an awful lot of tests on these children, but often the simplest thing to do is to initiate puberty. And if they grow at greater than 8 centimeters per year, you know they don't have an underlying chronic illness. If after 6 months it induces puberty, you know they don't have a significant underlying issue with pubertal suppression, and they probably have constitutional delay of growth and puberty. So I think a trial of estrogen or testosterone for 6 months or so is a really useful way and cheap way of working out whether there's an underlying problem that needs further investigation. So if you want to exclude a central cause, you can, particularly if your bone age is greater than 10, then you can do a bucerin stimulation test or a leuprolide or whatever your favorite stimulation test is. But I wouldn't use GnRH in RH. It's just not powerful enough, and you can be flat until 3 to 6 months before you actually go into puberty. So I don't think that's helpful. But one of the more potent stimulation tests can be helpful in this scenario. You can also perform definitive tests for central hypogonadism if there's early evidence of CNS damage. such as tumor or radiation, or if you have anosmia, then you're looking at the gene panels, etc. So I think these are things that we can look at. But if we just want to see whether this child will respond to estrogen, we can. One of the important things to remember, of course, is that unlike testosterone, which will eventually get converted to estrogen, estradiol will fuse your epiphyses rapidly, and you can lead to an attenuated pubertal growth spurt and shorter height. So you've got to be very careful using it. Oral estrogen appears to have a greater negative effect on pubertal height gain and can halve it in situations like Turner syndrome. And I think whilst the data is not great, the evidence that transdermal intramuscular estrogen improves pubertal height gain is still reasonable. We know in better studies that it does reduce free IGF-1, so probably by inducing hepatic growth, IGF binding proteins. But irrespective, I think that using transdermal estrogen, if you can, is a better way of maximizing both your growth and the side effect profile. So I tend to use beta estradiol patches, 25 microgram patch, and use 6.25 micrograms or a quarter of that weekly. You all probably aware that when it says a number like 25 micrograms daily, that's what you're getting. So the patch will give that irrespective of how long it's been on for, whether it's a 1 day, 2 days, or a week. So if it falls off, you put another patch on, you're not giving extra estradiol, it just releases that much per day. So just remember that if patches do fall off, which they do, you can just put another patch on without causing estrogen toxicity. And I would give that 6.25 micrograms weekly for at least 6 months, increasing after 6, possibly 12 months to 12.5. Mainly go up earlier if there's no increase in breast development, and that happens occasionally. If you need to use oral, ethinyl estradiol has been used a lot. That should be micrograms, not milligrams. 5 micrograms has been used, but it has an increased risk of thrombosis and is generally not suggested or recommended these days. Most people are using estrogen valerate or beta estradiol of 0.5 milligrams, increasing from there. And as I said, the key here is following these kids up. You watch that growth velocity over 6 months, and you want it to be more than 8 centimeters per year. If it's not, look for a growth disorder. Okay, look for something that's causing you to grow poorly, like an underlying chronic illness. Spontaneous puberty should also occur within a 6 to 12 month basis, and that does not occur. Consider investigating for other causes of pubertal failure. If you need to go on with feminization, if you have evidence of a permanent or long-term problem, either being primary or secondary, I would go for 6.25 micrograms, usually for a year, before increasing it, before doubling it and doubling it every 6 to 12 months until they're on 50 to 100 micrograms twice weekly. That usually takes 3 years, and then switching to a 30 to 35 microgram oral contraceptive, very much like Margaret was talking about previously. One of the important things to remember is that if you have normal cycling of a monthly oral contraceptive, that means for 3 out of 4 weeks you're getting estrogen, and 1 week or a quarter of the time you're getting no estrogen. And there's some nice studies suggesting that you get bone loss without the estrogen. So the current suggestions are that you should go for at least 3 continuous cycles before having a withdrawal bleed. You don't have to have withdrawal bleeds at all, of course. Combined estrogen progesterone pills do not cause endometrial thickening. You end up with a defective phase luteal endometrium, which doesn't change over time. So if someone wants to stay on a pill continuously, that is just fine. As also mentioned by Margaret, you may need a course of norelfisterone before you start, either 5 milligrams, and you can go up to 30 milligrams as she suggested, or medroxyprogesterone, 5 to 10 milligrams for 10 days prior to starting the oral contraceptive, to cause the endometrium to become more secretory and to be shed, and so you don't get the dysfunctional uterine bleeding that can occur otherwise. As mentioned, you can use oral forms, but just be aware that ethinyl estradiol can cause thrombosis, and as a consequence, we do prefer the patches. So to summarize, if you have poor estrogen growth velocity, less than 8 centimeters a year, after a trial of 6 months, consider underlying illnesses, including steroid medications, and undiagnosed skeletal dysplasia, pituitary abnormality, or quite commonly issues with compliance, which need to be addressed. If you're not entering puberty spontaneously after 6 to 12 months, consider a primary or a central defect. And if the bone age initially wasn't greater than 10, that's the sort of thing you want to assess then. Arranging a Buchanan stimulation test can be useful in this scenario, particularly when you've had a primed axis. A high baseline LH, obviously, and LH indicates primary gonadal failure. And with all of those, if you've got concerns of not entering puberty, I think a gene panel can be very helpful. So in summary, the assessment of early puberty is mainly clinical and observological. So just basically do growth measurements. Bone age is the only mandatory initial investigation. Delayed puberty is a symptom and not a diagnosis. And a trial of estrogen, ideally by transdermally, can differentiate normal variants from pathological problems. And I can't stress enough how useful gene panels are becoming in diagnosing cases. And I've picked up 2 charge syndromes in the last 2 years as a consequence of doing gene panels, which were otherwise unclear. On that point, I'd like to thank you for listening to me today. I'm happy to answer questions.
So thank you very much, Professor Hoffman, for your lucid talk. And we have got a few questions in the chat box, and I would like to start from the first one. What is the most specific biochemical or clinical marker to differentiate constitutional delay in growth and puberty from hypogonadotropic hypogonadism?
Great question, because there isn't one. Constitutional delay is a diagnosis of exclusion. Okay, and so you have to exclude other pathological causes to say definitively. When you go into puberty and you go through it at a later stage, then you can say they've got constitutional delay, but it's not something you can diagnose beforehand, unfortunately, particularly as it's the most common cause in boys, and it's probably the most common cause in girls too.
Thank you so much for that answer. Unlike in boys, where the induction of puberty in hypogonadotropic hypogonadism is preferred by using the gonadotropions, that is HCG and other, what is the preferred method of induction of puberty in girls with hypogonadotropic hypogonadism? Because in boys it is the intratesticular testosterone levels which are important. For what about girls? I mean, that is
another great question, and almost a data-free area. There is not a lot of data using FSH-LH combinations to induce puberty. I don't know of any. Most people, when they use estrogen. To be fair, the data in boys is still out. There's no good evidence suggesting that using LH, FSH, HCG is actually substantially better than using testosterone. Concerns have been raised about fertility, but I don't think they've been answered yet.
Thank you, sir. So how often do you find genetic testing to be useful in the diagnosis and management of hypogonadism?
Right. I'm finding that I'm getting positive tests somewhere between 20 to 70% of the time in selected cases. So in situations where I've given them a course of androgen or estrogen and there's been no response, over 6 months, there's been no increase, no spontaneous puberty, they've still got low LH and FSH levels, there's actually a very high pickup rate for genetic diseases.
Thank you, sir. And how often do you ask for an MRI brain once the hypogonadotropic hypogonadism is confirmed?
In everybody. So if you do have a proven central defect, I think you have to look at the brain in case there's something else going on that you don't know about.
Thank you so much for those answers, sir. Over to you, Dr. Sheikh.
Thank you, Dr. Paul. Good news for you is after 10 years, we are having another ISPAE meeting, ISPAE, APES, ISPAE meeting in Bangalore next year, November. So,
I'm looking forward to it.
Okay, you are invited and you will be here. And same to Dr. Olaf. And again, he's not new to us. He has been with us. He keeps visiting India for many, many reasons. And Dr. Olaf Hoyt is a professor of pediatrics from University of Lübeck, head of division pediatric endocrinology and diabetes. His scientific focus is on rare endocrine conditions of sex development and calcium and phosphate metabolism. He has coordinated several European projects regarding rare endocrine conditions, namely EuroDSD funded under 7th EU framework program and DSD net funded as a cost action under Horizon 2020. Currently, he serves as Deputy Coordinator and Pediatric Chair of European Reference Network for Rare Endocrine Conditions, ENDO-ERN. He is an honorary member of ISPAE. Welcome, Dr. Olaf, for this meeting today. I'm sure you always talk something new and very rare things we learn from you. So we are looking forward for your talk. Thank you very much.
Yeah, thank you very much for inviting me. And it's, of course, a big honor to be with you again. I'm just trying to share my screen here, and I hope you can see it. And I try to make it very practical because I think many of you listeners, I don't see you, are fellows, and you know what DSD or differences or disorders of sex development are. So, but first of all, I knew that, of course, Paul and Margaret would be here and many of you. So I pulled up this picture, which gives very nice memories of the ISPAE meeting. And that's why I mentioned the honorary member. I'm very proud of it. And hopefully we'll see each other again in the future, and best wishes for a good health to everyone. So when I prepared this talk, I thought that, of course, if you want to know about DSD, in an adolescent, many times it's a matter of diagnostic procedures, but it's also a matter of how to approach this child. This was the question. So I prepared 3 cases and scenarios of people that I know and that I'm currently following or that I have recently seen. So we'll go over the diagnostics a little bit, but have a focus on the management and how we in the European setting try to structure this management in a way that gives you a little bit of evidence. And of course, we want to make an outlook, especially of what is possible also in your country, being aware that, of course, there are many financial restrictions also from the patient side. So, and first, it takes a very good clinical look. So the first patient that I want to share with you is actually a person that I first saw at about the age of 10 years. He's living in the vicinity of Lübeck and was seen by a good colleague of mine who is a general practitioner or pediatrician, but has an education in pediatric endocrinology. And there this child was seen at the age of 9 years because of the clitoral enlargement. And my colleague, of course, took blood, and testosterone was elevated to 1.23 nanograms per ml, which is high. It's very high. And this child had been reluctant to go to the hospital because she had very bad experiences. She was born with a Ischemic syndrome, so a dextrocardia and a lung vein malformation. But there were some complications around the operation and surgical procedures right after birth, but it was essentially successful. And currently she has really no big problems of the heart. So when I saw her, her family history is unremarkable. There's no case of DSD or anything else. So I saw a young girl with a very good development, actually. And she had no syndromic features by looking at her, but we'll come to that later. There was no murmur, etc. What I saw was a really enlarged clitoris of 35 millimeters, which is very large. So it shows you that there is a high androgenization effect from which you don't know if it occurred. But of course, we in Germany or in the Western countries have a good, let's say, investigation of children at very set time points. And of course, since she had been operated, you would think that somebody would have seen a clitoral enlargement at those assessments. So it must have been a rather new feature or a combination. She also had, and this will be important later, strong hyperopia of 9 dioptrin. So when we took the lab, of course, in an adolescent, the lab is much more conclusive than in the young child. You see the highly elevated FSH. I don't give reference values in DSD patients of several things because it's the combination of several values. And because here you see the LH, which is, let's say, within a usual range for a pubertal child, the FSH is highly elevated. You see the testosterone, which is elevated for a girl, but something you would see also in PCOS or something like that. And you see, I like the inhibin B very much. You know, those of you to whom I have talked in the recent years know that I like it because it's a gonadotrophin independent Sertoli cell marker, of course, matching back with the FSH. So it's the let's say mirror image of LH testosterone is FSH and inhibin B. And of course, we did a karyotype, which came back in 46XY. So there's no doubt that this is a DSD condition. So, but what is it? From the highly elevated FSH, you can make the gonadal dysgenesis diagnosis because it shows you that there is a failure of ubiquitous failure of the testicular function, which affects both the testosterone issue because the testosterone is not higher than 1 nanograms per ml, and it also affects the FSH inhibin B axis. Is it syndromic? We have to go into this. What are further diagnoses that you want to do, and what's the management? We'll have the second case first. This is Mary, a child that came to attention about 3.5 years ago, late in 2018, from an outside hospital where she had had a herniectomy at the age of 12, so some months before. And the surgeon was clever because he found testicular structure in that herniectomy and sent her to a local pediatric endocrinology who had confirmed a 46XY karyotype. When you talk to these children, this is the first thing about management, don't be shy because many of these children are smart, and at the time of internet and good education at school, they are looking at everything. And Mary had said that she had felt that there was something different. She couldn't really palpate her vagina, and she said, I knew there was something difficult. So when you look at her, she's healthy. She has no past medical history that's of any relevance. Her clitoral length is also long and shows high androgenization. The gonads are not palpable, but on ultrasound, we saw that there was a structure behind the bladder that was small and long. So it was rather a vagina, not a uterus. And we could see the gonads in both inguinal canals, which resembled a testicular structure we will see in ultrasound picture later. If you see this androgenization without any puberty, because she was still B1, PH1, you of course have to draw blood, which is again revealing, because if you compare the two LHs, they are in the same range. So these girls, or these people have entered puberty. But in contrast to the first case, the FSH is low and the inhibin B is even high or within the normal range. Unfortunately, she was very reluctant to give blood, so we had very little material. And unfortunately, we couldn't measure some steroids, but we took testosterone, and you can see that it's very low. It's even within the upper range of what we would consider for a girl. So this makes you suspicious that this is probably an androgen biosynthesis defect. So how do you go on, and what's the management in those cases? The third case I just saw very recently, 2 months ago, 6 weeks ago. And this is also, again, like Mary, the case of, let's say, good, well-educated adolescent. She has primary amenorrhea, and she had also in 7th class or 7th grade, she had a biology lesson. And she said, I looked at myself and I found that I was different because the introitors looked different. And an outside gynecologist did a ultrasound and said there was no uterus, and her past medical history was unremarkable, except for a herniatomy at the age of 2, which you always have to note. She has 3 siblings. They are all fine and still in childhood. So the gynecologist said, this is a girl without a uterus. So they suspected Mayer-Rokitansky-Küster-Hauser syndrome and sent her to our DSD clinic. So what you do first is you look at the child, and if you see a normal breast development and an adequate positioning of pubic hair, of course you could go for Mayer-Rokitansky, but she had very little pubic hair. And we do ultrasound, and I like to do it myself, and I saw the lumps in both groins. And of course, then the differential diagnosis is something different. This is the ultrasound of a typical testicular architecture in the inguinal canal. I think those of you that do ultrasounds or see ultrasounds can easily see that. So what is the differential diagnosis? Of course, this is the elevation of LH, the high testosterone, the even elevated inhibin B, and the low FSH is the diagnosis, regardless of what else comes, of androgen insensitivity. And so she had a normal 46XY karyotype. Do you need further diagnostics? What's the management in those children? Yes, let's go for it. So the initial presentation of all of these children in adolescence is either hypo or hypervirilization and an abnormal or deviant pubertal development. So watch for the hair pattern and for the breast development. I didn't put in any people who have grown up as boys, but maybe we do that as another lecture at some point. And of course, in many of these children, the primary amenorrhea, the older they get. But remember, these children came to attention about the age of 10 to 12 years. So that's early, and you don't really call that primary amenorrhea at that point, but these children are smart, as we said. What you should do is, of course, do the laboratory and do the karyotype if you suspect a DSD condition. I think it's even in all countries, sorry, by now you have the technical means to go for an ultrasound, which usually is not that difficult and can reveal the Müllerian structures and the gonads for an experienced radiologist or endocrinologist. But it takes a message and a conversation between the radiology and endocrinology pediatrician, because you have to know what you're looking for. A radiologist just making a picture will usually not end up with a right interpretation. And we'll go into the genetic evaluation, because I strongly agree with Paul that more and more genetics is more revealing than some endocrine values. What it takes is actually a setting that involves quite a lot of endocrinologists, because we need DSD settings to keep these children in a very good setting regarding endocrinology, gynecology, but also psychology. And of course, it takes a lot of specialists around that, as we can see. And we usually do a lot of talking with these patients, giving transparency of any procedures, and revealing the suspicion of a DSD right away. So actually, when we go to the genetics, Samantha revealed a very interesting finding, which we are submitting the paper next week. It's just on my desktop, and after the session, I will go through the paper, because the exome sequencing, which we don't do panels anymore, because the exomes are much better technically these days. But then, of course, you set a filter and you look for things. And we found a gene that only our bioinformatics biologist found. He looked for a gene that would bring things together. And remember, she had the Schimitar syndrome with the dextrocardia, and she has this severe hyperopia with the partial gonadal dysgenesis. So we revealed a gene that's usually not found on DSD searches, that's called MERV. I will not go into this, but it's revealing, because I will have a video conference with this patient this week, giving her the molecular diagnosis and sending her to an ophthalmologist, because she has a high risk of revealing severe glaucoma. And of course, this has to be looked after. In Mary, of course, if you have difficulty in doing the androgen biosynthesis precursors, then go for genetic analysis. And as you have probably seen in the paper that we wrote with Dr. Rajni Sharma and Vandana Jain and the people from AIMS, it's good to do this. We found a homozygous mutation in HSD17B3. We know that a lot of people from India have 5-alpha reductase deficiency, and usually the genetics is easier in those cases than doing the ratios between different precursors, which takes you a lot of money and takes a long time. In Jolene, when you have a androgen insensitivity like that, we just do the sequencing of the androgen receptor for genetic counseling of the family, and to giving her a feedback. This is CAIS. This is complete androgen insensitivity. And this, of course, can be targeted sequencing. So we have a diagnosis on all three of them. And the question is what to do. They all came with an anxiety of the virilization or the self-investigation, like in Jolene's case. What we do is usually take the steam out. We tell them the diagnostic procedures that we do. And usually in many adolescents, we sometimes discuss with them of doing a GnRH analog therapy if virilization is occurring at a level that is clinically relevant. So in the first two cases, this is an option. So you give the perspective of that there are options for this child, and do a counseling in a time and age dependent manner about pubertal development, about the possibilities of a abnormal development or what you can do about it. Of course, sex and relationship is something that is moving for those children. They are just confronted with puberty. So don't take that out. It's a matter for them. And of course, fertility and family planning can be quite good. And if you want to read a paper about this, this paper in the Journal of Pediatric Urology has just come out from an American group. We published a paper in 2018 from the cost action that Dr. Sheila mentioned in my introduction. And it shows you how to approach a child during the different age ranges and what information to give. So if we talk about puberty, give the information they will find out anyway, check it with the knowledge they have, and tell them the perspective of becoming an adult. So they need to know about chromosomes, they need to know about the internal organs, they need to know about cancer surveillance if you want to do that. They need to know about gender, and of course they need to know about others that possibly have the same condition. They feel very alone. And because they feel alone, we in Germany, from the institutions that are shown below, have made a structured educational program for children with a DSD condition. You don't have to read it, it's in German, but it's like a 2-day event. And now, today and yesterday, for instance, we had an educational program for children with Turner syndrome. So it's a very structured way of bringing them knowledge. And yes, you can see we do it with 5 to 6 kids and their parents at the same time. They are separated, so the parents are in one room, children are in another room, and they get to have this knowledge. And what they all like about it is that they can exchange with other children that have the same underlying condition. About puberty induction, of course, what we sometimes do is that we block the endogenous puberty, and we have other means of induction of puberty, or the children have been gonadectomized or whatever. They have no gonadal function. You can do a pubertal induction and do a sex hormone replacement of the wished sex development. And I'm very glad to my colleague Anna Nordenström from Karolinska, with several other people from Europe, because within the ENDO-ERN, the European Reference Network, we have made a guideline which is soon to appear and is accessible for you, together with the European societies ESE and ESPE, on the possible hormonal treatments. And as you can see from this slide, many of the conditions were gone through. There's little evidence-based medicine, but a lot of experience. So in this paper, you can find modes of pubertal induction, what's known, and also fertility options, which are very important to many of these patients. So what happened to our 3 patients? Well, with Samantha, she is very established in her female role. She is now 16 years old, so she has adapted to the situation. We did the GnRH analog therapy, but since she was so stable in her pubertal role, of course, she wants to enter the female puberty, and we gave her estradiol for induction of puberty. And in Germany, we are very reluctant to remove, let's say, at least partially functional gonads in adolescents, because it's a procedure which they sometimes think it's very massive. And of course, also the laws currently, the legal situation is restrictive. So, but we say that the GnRH analog therapy can be done for years, and we will continue it until informed consent and legal consent is possible. It was different in the second child with the 17-beta HSD deficiency. This child was very insecure about gender development because she thought that she is, well, a self-explanatory intersex. So actually she is now 15 and is giving it a trial of male gender assignment, which was very well received by her classmates, interestingly. So she stabilized, and now she discontinued the GnRH analogs and is going into her, let's say, usual male puberty, where we counseled her that testosterone will surge because alternative enzymes will take over for the defective 17-beta HSD type 3. And as we have shown earlier, they will have a strong virilization. So she knows about the consequences. With the complete androgen insensitivity, you can be really set back because usually they are very stable in their female role. She did this 2-day educational program. She's well informed, and there's no need to give any medication. She will have regular gonadal ultrasound and gynecological exam when she's fit to do this, and then we will talk to her about vaginal length, etc., etc. In a book that I think that's about to appear in India, I was invited by Dr. Menon and others on DSD for pediatric endocrine disorders, a book which probably you will all get. And with Dr. Rajni and Dr. Vandana, we wrote this work, and I hope you can still hear me. However, it gives you a guideline how to approach a child with primary amenorrhea, and many of the thoughts that we had that, of course, globally exist for approach to a patient with DSD, but also taken into account the special situations and cultural issues that have to be taken into account in India. So if you have adolescents with DSD, don't forget about the transition to adult specialist. All patients during puberty, a time of a lot of insecurity and entering adulthood, it needs psychological counseling. This is mandatory. So we don't give the patient an option, go to a psychologist. The psychologist is a team member and sees the patient together with the doctors. You need endocrinology because you, of course, have to look for the pubertal development for the endocrine evaluation. And you also need gynecology and urology. Think that many of these people have fertility issues. We're not talking about Turner's now, but of course, we did the schooling about Turner yesterday, and it's a matter. Some people really drift away due to the complications they have in puberty, and now they have a DSD issue. So some people not only need psychology, but they need psychiatry. And as I've told you with Samantha, a lot of people need other specialists, and you need to transition this into adulthood. Transition means that the patient has to have extreme good knowledge about the condition, about any medication that they take, and about the specialist they need. So a transition needs a transmitter, which are you. It needs a message which has to be conveyed to the patient, and a receiver, meaning a doctor that really takes care of these patients. With this, we come to the outlook. Yeah, and I think that's fertility. It's something that we just grasp in DSD. We were thinking many years only about the diagnosis. Now I think the management issues have come up as the main issue. Think about uterus transplantation, which is actually done for Mayer-Ruticular-Kuster-Hauser syndrome. Will we have discussions about doing this in AIS? What do we do then? How do we manage this? We've heard from Paul about the medications for hypo, which of course also gives the aspects of fertility despite high cost and a lot of interventions. We know about the testicular procedures with TACE, etc., for Klinefelters, which gives them very good fertility options. And what do we do about gonadal dysgenesis? Will an oocyte donation be an option for Samantha? Will this marry if the transition to a male, will that lead to fertility? Many questions that we have to answer, which I can't answer, but I send you greetings again from Lübeck, which actually looks like this today with a lot of sunshine, but of course we have leaves on the trees. This picture was taken in the winter. Thank you very much, and I'm open for any questions.
So thank you, Dr. Olaf, for the wonderful talk. And there are a few questions which I would like to ask. So what should be the interval between 2 consultations, and how many consultations on an average your team requires to go for a definitive management?
Well, when I see somebody like this young girl, Jolene, with complete androgen insensitivity, I can do quite a lot of things at that time. For instance, the ultrasound, as I do it myself, I have immediately the issue of the testes, for instance. The blood draws here in Lübeck come back within 2 or 3 days. So I'm very happy that we'll have all the results from the endocrine evaluation quite on a very short notice, but of course a karyotype takes probably some weeks or so. So usually what we do in these days, where we have also video possibilities, we see the patient if they come from the vicinity after 3-4 weeks to go through the results with them. Or if the patients, even in Germany, travel quite a bit because we have the DSD centers and there are not so many, then we do a video conference to explain the results with them once they have arrived. For this girl with androgen insensitivity, we usually have consultations about every 6 months. Once they are stably informed. For the others, it depends. Like I said, for this girl, it took a month to years to have this very complicated genetic results for the syndromic form of DSD. Then, of course, I also made a video conference to explain this to her, so we don't have any delay, and for instance, in getting her to the ophthalmologist for the glaucoma issue. So there are many issues. Also, our psychologist does video conferences if needed, and they come back whenever they need to, but usually we have like intervals of 6 months to 12 months for visits on site.
Thank you for that answer. Can you please enlighten us on the minimum team members required for a multidisciplinary team, particularly in India, the resource limited setting?
Yeah, but it's also not so easy in the Western world because it's always difficult to bring people to really do this together. And the idea currently is that we have a setting initially of, let's say, if they are adolescents and children, of the pediatrician, pediatric endocrinologist, we always have a psychologist at the first meeting. So DSD clinics requires the psychologist to be sitting at your desk. So it's not, okay, after this talking to me, you go to a psychologist. She's the one who actually does the take-in interview. Otherwise, we wouldn't have we wouldn't have knowledge about this information of self-investigation, what the patient actually already knew. So if I, as a physician, talk to the patient, I have to know how the psychologist rates this patient. So that's mandatory. In Lübeck, we have the good thing that I have a very good friend who is the head of pediatric surgery, which does not mean that he gets the knife out right away, but he's the one who assesses with me the ultrasound, for instance. But if you have a good radiologist doing that with you, it also needs a good communication, as I've said. because many times in girls, they look for ovaries, which they don't find or whatever. They don't know if it's a vagina or a uterus. So it really needs a hands-on communication. So it needs an imaging person, it needs the psychologist, and it needs the pediatrician. You can have also a gynecologist if you have an older adolescent, or a urologist at hand if you need that, because I know also in India people travel a lot, so you have to offer them something. Once you have them, later on you can do the results via video conferencing if they come from far away.
Yeah, thank you so much for that. The next question is particularly about a patient in 5-alpha reductase deficiency brought for voice change with early stage of puberty. The child was reared as female and identifies as female. What should be the ideal management or continuing this? Considering the setting in our country, the voice change, our team feels that it is better to be reared as male, and parents are not willing for any GnRH, analog depot for postponing the puberty. So how
this we could do another a whole meeting about, I think, a whole symposium over several days. But I didn't actually put this case in because it's so complicated. I have several families with 5-alpha reductase deficiency, and even within siblings, the attitude can be quite different because, of course, I think it's hard, but it's on the other hand easy to imagine what it means for an adolescent in an insecure period to change gender. It has to be accepted by the person, but by the environment, etc. On the other hand, several of these children actually opt to go for a male gender, even in our settings, because they feel like it and it's accepted. I know that in your country, of course, it's a different country and it's a different cultural setting. So you really have to discuss this option. Once the voice is deep, it's very hard to change that again. On the other hand, there are, I don't know what you call it, linguistic professionals, logopedics, who can do that, because in the Western world, we have an increasing number of transgender people who change in adulthood. So even when you change from male to female, you have to learn how to go with your voice. And so there are means of training your voice to have a higher pitch. On the other hand, it's difficult for these people because when they are on the telephone or something like that, they are always addressed as males, although they want to live in a female gender. I mean, I know it's costly, but the GnRH analog therapy, as I said, takes a lot of steam out of the situation. So if you have means of doing that with a 3-monthly injection, trinantone or whatever you call it, I think it gives you time to discuss these options with the family. And of course, the last discussion point is if you have the option, and I know that you have also quite a lot of 5-alpha patients, bring them together maybe for an educational event if you can, because when the children see their options in other peers, we call it peer counseling, they can make the decision on the grounds of experience, otherwise they feel very alone. And so if you have seen other patients that have, for instance, gone through the transition of changing their gender, maybe they consider it. But it's a very individual decision-making process, and it's extremely difficult.
Thank you so much for that. So one last question is there. How often FISH or SRY gene analysis helps you in the diagnosis?
Well, we were discussing that with in the daily conference, but just before the pandemic, etc. Of course, in your setting, it really depends on the economic situation of the family or of the institution. I was intrigued to see that, of course, assessment of an endocrine profile is difficult in your country because you don't have the LC tandem MS means in institutions, etc. So values are sent out to other countries to measure. And we discussed this with Dr. Vandana and Dr. Viji and many others. And I think you have to make a decision that genetic analysis is probably in many cases not that expensive anymore and gives you good information. We all know that sometimes you find variants of unknown significance and you don't know what to do with it. So it needs a very good biomathematician or bioinformatics person that knows about DSD and what to do. I think this is, again, a transition period currently where we as endocrinologists have to see where's the value of endocrinology. I hope I have shown you that in my case presentations. But of course, at the very end, we in our country usually do an exome and only targeted sequencing if we are very suspicious of one certain diagnosis. I mean, an exome in our country is now 300 euros, which is not so much money, but I know how much money it is in India.
So, thank you, Professor, for that answer. One more question we have from Professor Raghupati. Should we consider GnRH analog therapy as experimental, or is it well acknowledged as regular therapy to be tried in this situation?
Well, as you will see from the paper of Anna Nordenström and others, of course, it's a therapy that is not evidence-based because we have had no trials in DSD. So it's a matter of experience rather than evidence. But we all know from precocious puberty how good it is. So from that way, it's also something that is, of course, reversible. It's very good accepted. So usually our healthcare insurance, which is very well, it reimburses on evidence-based grounds. It's paying for those patients because they know that they are rare patients. On the other hand, the evidence for a good suppression of a pubertal development is well known. So I think this is what we have to acknowledge currently.
Thank you so much, Professor.
Thank you, Professor.
So before I go on for the vote of thanks, I would like Dr. Shaila to have her final.
Yeah. Thank you very much, Hari. Thank you very much, Margaret, Dr. Paul and Dr. Olaf. I think today we have had a really good adolescent discussion, endocrine problems, very common menstrual problems, not very uncommon delayed puberty, but rarer DSDs where we miss many of them. So I think it was an excellent session. Thank you for your time on Sunday. And Margaret is traveling, so she had to leave early. Really appreciate, and we again welcome you to India and to Bangalore next year. Thank you, for a physical meeting.
Thank you.
Take good care. Nice seeing you again. Greetings to everyone whom I couldn't see. Bye-bye.
Bye.
Yeah,
Hari, thank you.
yeah. I would like to thank our expert speakers, Professor Zakrin, Professor Hoffman, and Professor Hyatt for the wonderful lucid talk. I would like to thank the delegates who have joined in on a Sunday morning, taken out their precious time. I would like to thank Dr. Shaila Bhattacharya for her continuous support and guidance for arranging and organizing this meeting. And I would also like to thank Divya for her